55-year-old male who presented with the complaints of floaters for past 1 week. Upon examination, the right eye had a vision of 20/100 with shallow retinal detachment nasally and inferiorly. Posterior vitreous detachment was noted and there was resolving pre-retinal hemorrhage. Intraoperatively, a giant retinal tear of more than 270 degrees was identified. After completing the vitrectomy, the edges of GRT were cauterized. Due to inability to pass the light pipe through the trocar was removed and the port site was increased in size. And PFCL was placed to flatten the retina. A 25-gauge laser probe was placed through the superotemporal sclerotomy edges, but the trocar was not placed as it was coming out due to the large sclerotomy opening. Initially, the laser was attempted to the margins of GRT. Repeated entries with the laser probe were done through the open sclerotomy wound. Due to the inability to laser the anterior edges, the surgeon shifted to cryotherapy and the two horns of the anterior flap of the GRT were treated with cryotherapy. Following the cryotherapy, a shiny foreign body was noted superiorly. Upon closer inspection, it was identified as the tip of a laser probe. To remove this foreign body, maxi-grip forceps was used to bring it anteriorly. The other end of the probe was held with forceps through a second port and the foreign body was removed using the handshake technique. After suturing the port site and securing the ports, the retina was examined and a suspicious retinal break area was noted at the site of the foreign body. This break was then encircled with continuous laser marks. At the end of the surgery, PFCL air exchange was done, followed by silicone oil implantation. In conclusion, the risk factors for this complication could include a weaker laser probe preoperatively, repeated attempts at passage of laser probe through open sclerotomy wound instead of passing through the trocar, the usage of 25-gauge cylinder laser probe through a larger 23-gauge sclerotomy opening, resulting in excessive mobility and bending of the probe while treating the anterior edge of GRT. Similar cases involving intraocular loss of phaco probe tips and scissor tips have been reported. Thus, careful handling of instruments, using appropriate gauge as per trocar size, and avoiding passage of laser probe through the open sclerotomy wound instead of trocar can reduce the risk of unexpected intraocular foreign bodies.
60-year-old diabetic phakic patient presented with vision limited to hand movements and was diagnosed with a subhyaloid hemorrhage and tractional retinal detachment involving the macula. The patient was scheduled for pars plana vitrectomy, membrane peeling, silicone oil injection, and endolaser. After performing the truncation and core vitrectomy, the membrane was separated from the underlying retina using chandelier illumination and a bimanual technique. During the removal of the membrane with forceps and scissors, it was noticed that one of the tips of the scissors was angulated. On close inspection, one of the tip fell off and was carefully removed using forceps and the handshake technique. The scissor tip was aligned along the long axis for smooth removal through the port site without the lens touch. The surgery was then completed by using another set of scissors and a cutter to remove the underlying membranes. This was followed by fluid air exchange, endolaser treatment, and silicone oil injection. The probable cause for this unexpected complication can be the reuse of instruments, which might have led to rusting and impaired maneuvering. In this case of coloboma cataract, the cataractus lens was planned to be removed via the pars plana route. During the surgery, while using the phacofragmatome to remove the cataractus lens, we can see that the tip of the instrument broke and fell into the vitreous cavity. The broken tip was carefully removed using the forceps. The tip was held along the long axis. The phacofragmatome entry site was then extended to facilitate the smooth removal of the broken tip. These cases underscore the critical importance of proper instrument management in ocular surgeries. The reuse of instruments such as scissors, phacofragmatome tips raises concern about the potential wear and tear, rusting, and compromised integrity, which can lead to unexpected failures during the delicate procedures. Similarly, inappropriate gauge selection, as seen with the use of 25 gauge laser probe through a larger 23 gauge sclerotomy, can result in excessive instrument mobility, increasing the risk of bending or breaking. These incidents emphasize the need for meticulous handling and selection of surgical tools to prevent the intraocular foreign body. These can complicate the procedure, endanger the patient's vision, and require additional corrective measures. Ensuring that instruments are in optimal condition and appropriately matched to the surgical setting is crucial for maintaining the safety and success of ocular surgeries.